Today's lecture aims to introduce health technology assessment, which is one of the fast-growing new topics within the wider scene of biomedical engineering. And at the end of this presentation, in about 40 minutes, I will give you also a small introduction in what my group, my colleagues and myself are doing in this direction in terms of research. Something that I'm sure you are aware, but it's worth of mentioning. We are at Russell Group University. Russell Group University, you know, what does it mean? We are those universities in the UK in which our teaching is very much research-driven and informed. So all of us, we are active researchers. There are other universities in the world which are mainly teaching-oriented. Our university is one of the Russell Group, meaning that we are research-oriented teaching institution, which means that whatever you will see here is very close to what we do in our research. Okay, so many of the things, many of the lectures that we give, perhaps will not come with a book or a chapter of a book, because books have not been written on what we are doing now in terms of research. So we can give you articles and things that will end up in a book in a few years' time. So keep in mind this distinction, because especially for biomedical engineering, also if you end up selling medical devices, having an idea of what's going on in terms of research is fundamental, because that's the way, that's what really drives the market of medical devices, research, clinical outcome, clinical results. Otherwise, you cannot even sell a medical device with the new regulation. Okay, today's lecture, as I was saying, we cover a topic, health technology assessment, which is one of the fast-growing topics, also one of the last which has been introduced among the core topics of biomedical engineering. For those of you interested, I can circulate the paper, which will give you an idea of what the IFMB, which is the International Community of Biomedical Engineering, consider as core topics for biomedical engineering. And that technology assessment was the last one introduced among the 5 core topics of biomedical engineering. And it's very fast growing. Before we enter into the topic, I need to share with you some basic definitions. As engineers, we are used to model the reality on which we have to work. And modeling has some pro and some contra. Clearly, it's an abstraction of reality. So every time you introduce a model, you are introducing some complexity which you need to consider. But our approaches are very effective. In any branch of engineering, we tend to model things in this way. We consider our process, our system, our service, our device as a box. Preliminary, can even model this as a black box. We don't know what it is inside. What we know for sure is that there is an input that enters this model, and there is an output. Now, if you were, building a plant producing energy, perhaps this would have been coil, and this would have been energy, power. If you were working in any other field of engineering, I don't know, electronic engineering, this would have been an electronic system. You would have had, continuous voltage current entering from this side, and something else going out from there. A movie, a video, an output. Because we are biomedical engineers, we work in healthcare, that's what we model. Processes of care. So whatever we need to do, whatever kind of knowledge we need to do together with devices, procedures, drugs, and personnel, and we need to use those things in order to deliver. So we have as an input those plus other things that you see here. So workers, budget, knowledge, devices, building, hospitals. We transform all those things, perhaps within an hospital, and we produce an output, which is, we are an hospital, number of beds, number of visits per day we can deliver, whatever, according to the level you are modeling, this is a possible output. But in healthcare, output is not the final point. If you were doing aircraft, this would have been most likely the final point. But if you work in healthcare, you are not interested really in the output. but in the outcome. Or at least it's worth for you to make a distinction between output and outcome. Outcome is actually what your output makes as a difference in terms of health. So the clinical outcome is what you really measure for a medical device as a result on the patient. Depends from what you are doing. If it is minimal invasive surgery versus open surgery, you will use as outcome, I don't know, loss of blood, mortality, morbidity, whatever, it's a relevant clinical outcome. But what I would like you to focus today on is that I may have the same number of beds of another hospital, but be much more good in improving the health of patients. We may have two hospitals which have exactly the same number of beds, but one of the two is saving twice the life than another. Now, this can be partially due to what we model as external factors. I don't know. One hospital is in an area which has twice the pollution than my hospital, which means that if they are working on lungs or severe allergies or many other things, their clinical outcome will also be affected by the local external factors. Or for instance, behaviors. We tend to be as global as we can in this model. So we know that across the world there are different habits, different diets, different attitude to bad lifestyles. I don't know, smoking is now much more diffused in some parts of the world than they are anymore in the UK. In the UK it was diffused 20 years ago. So there are some factors which affect the ambient and the behavior of patients, which obviously will have an impact on the outcome. But, say so, we need to learn that we make a fundamental distinction between output and outcome. If you don't appreciate this distinction, then you are less effective than efficient. Let's introduce few definitions. Efficiency. Efficiency is defined as the output divided by the input. Efficiency is how many kilometers your car will do with the liter of fuel. That's a concept which is very general. And in engineering in particular, we use this concept everywhere. We have the Carnot cycle, we have many fields of engineering in which we use this definition. And again, you use it in everyday life. You can be twice efficient in the way you drive your car. And my way of driving my car, I make my car arriving far with the same amount of fuel than someone else, with the same car. But as I mentioned before, in healthcare we have two levels, output and outcome. And we need to measure this difference. And the way we do that in healthcare is introducing the concept of efficacy. So you have a clinical outcome divided by an output, which means that how many lives you manage to save with your beds, with all the beds you have in your hospital, how many oncological problems you manage to discover with the same number of diagnostic images you do in your hospital, or relevant, how many oncological problems you manage to see with this technology compared to the other. So that's what we try to do. With different technology, assuming the same input, which one is more effective? We have two words, efficacy and effectiveness. Efficacy is how far you arrive in terms of clinical outcome during a trial, during an experiment. Because we have conditions during the experiment which are far more easy to manage. We know better the patient, most likely the clinicians running the trial are the most skilled one in the country, and things like that. Then when you enter in real life, you have the so-called effectiveness, which is normally lower than the efficacy. It has the same definition, but the effectiveness is the efficacy in real life. Where patients, they behave in a different manner because they know that they are not anymore in a trial, so they will not be assessed after 6 months. Clinicians, they have other than just research to do, so they need to be working in a different way. But we can use it as efficacy or effectiveness during this lecture because we want to and then obviously we can combine both, and we will talk then about performance. Performance is the ratio of outcome on input. So without using the intermediate measure, which is the output, we want to know, given some input, what it is your capability to produce effect on patient life. Okay, sorry for those few but needed introduction, because then we will use there in our what it is an health technology assessment? An health technology assessment is a structured process, scientific process, which aims to inform public decisions, political decisions regarding healthcare technologies. What is an healthcare technology? An healthcare technology is defined by WHO as any form of organized knowledge which is specifically meant in order to have an impact on the care, on the health of patients or population. Meaning that health technology is a wider concept than medical device. Health technologies include both medical devices, drug, clinical procedure, any form of organized knowledge. Now, in order to assess any form of organized knowledge, in our case would be mainly medical devices, what should we do? First of all, we need to be aware of what are exactly the needs that we are trying to satisfy with our technology. For instance, if I have a fever, what is the need I need to satisfy? Guess. Well, guess we have a medical doctor. What is our first need? What should we do? Yes. If you have a kid with fever, what is the first and most important thing to do? Eh? Check the temperature. But why you want to check the temperature? Because you want to lower it. So the need, if you have a fever, is to lower the temperature in the shortest possible time, especially if the temperature is very high. So the need is not to measure the temperature. The need is to lower the temperature. Fair enough. As you see, there is confusion. Even in the first thing that you can experience in your life as a form of healthcare problems, there is confusion. We are not trained in order to distinguish exactly what is the need that we need to satisfy, the procedure, in this case, taking the temperature and entering the procedure, the media to use, in this case would be the thermometer, the solution to give, which can be a drug or can be a cold shower. Don't care. They both will be, in this context, considered as healthcare technologies. When I say need analysis, I mean, first of all, to identify, and we did now, lowering the temperature. But there may be, in more complex cases, more than one need. So you may have a patient may have a disease in which it's important both to reduce pain, but then also to do something in order to, I don't know, increase mobility. That's very common in many diseases, that there is more than one clinical outcome that we need to satisfy. And then, once I have identified all the needs, then I will tend to classify them in consistent categories, and then, most likely, I will need to prioritize those which are more important. Because when I will go to compare a medical device with another, most likely I can just focus on the most important clinical outcome. Because most likely I will not have all the information to judge all the clinical outcomes. Perfect. Once I do that, then I start identifying the existing technologies which can be used in order to solve this problem, to satisfy this peculiar need. And once I do that, I will most likely try to make a multidimensional evaluation, meaning that I start from the clinical domain. I want to know which technology is more effective in reducing mortality. But then, once those clinical outcomes are about at the same level, I will start considering other domains. For instance, I will start making some ethical considerations. And if I am doing this assessment in the UK, where the National Health Service is delivered with public money, I need to also consider the perspective of the society as a whole. For instance, when we are in in any system in which the National Health Service is paid with public money, we need to know that the budget is limited. Whatever we do, the budget is limited because even if we are in a very rich country, we make a budgeting at some point, and we define the budget that we will use for this activity, I don't know, for the next year, 3 years, 5 years, whatever. Once it is defined, it's more or less all the budget you have, which means that if you want to introduce another medical device, an innovation, which will have a cost, you need to take off something else. In healthcare, especially when we have a public healthcare service, every time you introduce a medical device, you have to be aware that you are taking off something else. And one of the main complexities of health technology assessment is that if I introduce an intervention for a specific pathology, it could be that I'm taking off something not for the same kind of population. For instance, if I am introducing an innovation for pediatric surgery, perhaps I will need to take off a budget from something completely different, geriatrics. To do that, I need to define a comparator which is wide enough in order to compare the impact on the social scale on pediatric patient versus the impact on the social scale of geriatric patients. So it's not easy, and I need to consider the impact on society, because the society is paying for this intervention. According to the scale on which I'm working, clinical intervention, then I will work on the clinical domain. But if it is a public health intervention, the campaign to prevent people start smoking, then I will work on epidemiological level, which is pulling medical or healthcare information at global scale. And obviously I will need to consider the economical domain, because I mentioned before, our budget is every time limited, sometimes even scarce, and I need to be aware that when I introduce a technology, I'm taking off budget from something else. So I need to balance what is the advantage of introducing a new technology against removing something else. Once I have done this assessment, I will need to put all the data together. I will need to analyze, and I will need to compare a clinical information with an economical information. And that's when the problems will start arising. And we'll see the solutions we adopted in the UK. At any point of the cycle, you may have a look at that, and you may decide that one of the technology that you first considered appropriate, then it's not, for any of those reasons, or something that you have not considered before is coming out, and perhaps you want to enrich your comparison, including other technologies. And then, once you have done all those analyses, you will start to measure the things that we mentioned before. The efficacy, which means the clinical outcome, the impact on the patient, the efficiency, which means that given this outcome, which technology is using less resources, and the performance, which we try to put the two things together. Why do I do both? Why do we do such a complicated analysis when it comes to medical devices? Yes. I know it's 9 a.m.
So big impact on people's lives?
Those technologies have a big impact on people's life. That's the kind of reason. But also more. But you can do those assessments for other than healthcare domain. Why? Because we are in a domain in which there is a clear asymmetry of knowledge. We have all the knowledge which is needed as engineers when it comes to the device. We don't have all the knowledge regarding the clinical problem. Clinical colleagues, they have all the knowledge they can have regarding the clinical problems, but they don't have the knowledge about the device. If I was producing aircraft with yesterday, most likely the final guy driving the airplane is an engineer. We have the same background, or more or less an engineer. So we understand each one the other, and we both understand the technology this guy is driving. But when you are a biomedical engineer, you produce medical devices which are then used if you're lucky from the patient. But more and more, if you're lucky from the clinician, but more and more from the patient, which means that you even don't have a professional trained person to use your device. So that's why you need to inform the decisions regarding medical device. You have to give a contribution to inform, because together with you, when you run an economic assessment, there will be an economist, there will be a clinician, there will be other people which they will help you gathering information in the domains in which you are not the most experienced person. And you will provide information regarding bigger domain. Then, the more you understand of the other domains, the better you will serve the economic assessment process. And in fact, at this level, we need to disseminate our information. And that's again challenging, because most likely, if you're working at national level, your study is informing the decisions which a politician will take. Politician, if you're like maybe a medical doctor, if you are lucky, maybe an engineer, but it could have a completely different background, history. In which case, you need also to pay an effort in order to make the results of your assessment intelligible to someone who just not the same background you do. So that's the level of complexity, and the information you provide, they have to be clear, unequivocal, and you have to prove which word you say, because after your study, there will be taken decisions on which life will depend. So you need to prove at any moment, even 10 years later, what you did then, it was the best you could have done with the available knowledge. So you need to track step by step whatever you take as a decision. And last but not least, you need to monitor the data, because what it is cost effective today may become less cost effective in 1 year. Or the other way around, what is not cost effective today may become cost effective in a couple of years. Because the cost of technology evolves in time. Let's focus on those two domains, efficacy and efficiency, which means clinical outcome and budget. What do we do in the UK? In the UK, we have a National Health Service. What is the difference between National Health Service and the National Health System? Is it clear to you, this distinction? You see, we use those words every day in our life, but the technicality which is behind, it's what do you think is the difference between an healthcare service or a healthcare system?
A system you have to go into where the service is provided to you. Is that right?
No. Thank you for that. No. A system is wider than a service. A system is what you have globally in a nation, which includes the service, which is what is provided with public money in the UK, plus private insurance, private clinics, private drugs if you want to buy, direct access to medical device. I mean, I take money out of my pocket and I buy whatever medical device I can buy if I am allowed. So I may have an healthcare service, which is what we know in terms of the majority of trusts in the UK. Then I may have services which are not provided by the NHS with public money. I don't know, certainly you have this experience with the odontologic surgery. Some of the problems are covered by the NHS, but whatever it becomes to be more aesthetic, it becomes to be more personal. And is not all provided with public money. So the NHS is altogether what we provide in the UK with public money, with taxpayers. Throughout taxpayers, in the UK we have a global access to our NHS, so even someone which is in the UK without permission to be here, we provide healthcare. And there is a reason for that, because otherwise, if there is a pandemic, the general population will suffer. So it's more convenient to do than it is not, apart being ethically correct. But so, NHS, National Health Service, is what we provide with the taxpayers' contribution in the UK. Another country can be what you provide with the public insurance, for instance. And then there is part of the services which is covered with private money, and it's not offered by the NHS. And the example of both, it's called the National Health System. Normally, when we focus on health assessment, we keep in mind the National Health Service. So the effort we make with public or with insurance. Okay? Because this is where the budget is. Now, what we do in detail is this. We consider a benchmark. And let's imagine that you guys, with your project, will produce a fantastic innovation, which is a new medical device, which is very promising in terms of treating a disease. The first thing to do is, okay, this is in this moment the technology that is used in the NHS to solve exactly the same problem. If there is a problem, most likely you didn't invent the problem. So the problem is already there, and most likely there is already a solution. Now, against this solution, that's what you need to position your innovation and to prove that it is more effective or eventually less effective. Most likely, if you are spending your time on something which you think is promising, it's because you are more effective. But also you need to prove if you are more costly or cheaper than the benchmark. So I'm producing a fantastic new medical device, and I want to prove that my device is more effective. Most likely it will be also more expensive because it requires some investment in terms of new production, research, and so on and so on. But in some cases, it can be also cheaper because although the cost of the device is higher, I can prove that the cost over a span of time, which I can define, I don't know, 1 year, 6 months, 3 years, is cheaper because you have an initial cost which is high, then you save a lot of money in terms of treating the patient later on. So there could be any of those situations, but independently, you need to position yourself on this diagram, which is called cost efficacy. And you need to understand if you are in this region in which you are less effective and more expensive than your benchmark. You lose. Benchmark is doing better than you can. It happens because you think that you are going to be more effective, you have some preliminary data in your lab, and then when you go out from your lab, you measure the real impact on your lives. And you see that things are going in a different way. So against your initial prediction, the real clinical impact is lower. It happens every day. And most likely when you do an innovation, you are more costly than the benchmark, at least as initial cost. But on the other side, you can be more effective and save budget to the NHS. That's where we are to. In this case, we say that new technology is dominant respect to the benchmark because it's more effective and less costly. But in the majority of cases, you will lie here because you are more effective, but you also require an investment, at least in the first years. What do we do if you are there? What can we do? You need to convince your taxpayers that your innovation is worth of their money. Not only that, you have to be responsible because if I introduce this medical device, which is treating, males in my age, I'm taking budget from something else, pediatric surgery, gerontological interventions. I need to be responsible, and I need to be aware, and I need to prove that on a global scale, it's convenient to invest in this budget rather than in something else. So whatever you do in economy is competitive. The concept which is behind the economy is competition. But also in healthcare, this is twice important because we have responsibilities and limited budget. So what happens is that there are common thresholds, which are called willingness to pay. So with some health economic study, we define a willingness to pay, which is actually a threshold. A threshold which tells you, okay, if you are that effective, that's how much you can cost more than the benchmark. If you are less effective, you can cost, your marginal cost, your additional cost is limited. This threshold may change according to the nation you are, may change according to times. So perhaps we are already observing the lowering the threshold in willingness to pay in the UK. Historically, it was considered to be £30,000 per audit, even when it is a audit. It's a unit of measure of quality of life. And now we tend to go towards the £20,000 per audit. So there has been a lowering in this threshold. And again, this threshold, that's what you do. If you have an increase in effectiveness against the benchmark of 10%, you may have an maximum increase in terms of cost of 20%. If you double 20% impact plus impact on the compared to the benchmark, then you can do 4 times more in terms of additional cost to the NHS. And if you are below this threshold, and that's what, the more you go there, it's green, the more you go there, it's red. If you are below this threshold, you are most likely to be introduced into the NHS. It's not the only condition, but it's the most, it's one of the main drivers in the UK to be admitted into the NHS. If you have an innovation, you need to prove that you have it. Which is why I am spending this hour of your time today, because you are biomedical engineers, you will be biomedical engineers, and you will work on producing innovation in healthcare. If you don't know what are the drivers for the final decisions, you will never succeed. You cannot be blind and just discover the last moment that someone will make this kind of reasoning on your device. What's the point? If you consider this thing fairly in advance, now that you are sitting there, now that you are starting your projects, now that you are eventually already having an idea in your mind, then it's more likely that you will have an impact. That's the reason why we invest a lot of time in my module, 1/3, it's about ethic progresses. And that's also why, on the global scale, this is the fastest growing field in biomedical engineering, because now we know that we need to have an impact. This is the same diagram we were observing before, but just the upper left part, the one in which we need to achieve a maximum threshold. Let's imagine that this is the benchmark. And then I have 2 innovative technologies, which after I do an assessment, which you don't know yet how, but in my module you will learn how to perform this kind of assessment. You have 2 technologies which are claiming they solve the same problem. There is evidence, clinical evidence, randomized control trial, meta-analysis. You don't have yet those concepts, you will acquire them by the end of January next year. And according to the best available evidence, technology number 2 is increasing the outcome of 30%. That's what it means this time. Technology number 3, it's more effective. It's increasing the clinical outcome of 40%, which means reducing mortality of 40%, or reducing pain of 40%, or prolonging life at a good level of quality of 40%, whatever it means. But the first one is £30,000, and the first one costs £7,000, more than the benchmark. So this is not the total cost, but if the benchmark is 10,000, it means the new one costs 13,000 per year per patient. That's what we tend to consider. Or per year on the population. Depends how you measure the effect. On the individual patient as an average, or on the patient as a population. Which technology would you adopt, if any? So would you stay on the benchmark? Would you suggest number 2? Would you suggest number 3? Who is for the benchmark? Raise your hand. No one for the benchmark? Fine. Who is for the number 2? 4 people, 5 people, 5 enough. Who is for the number 3? 1 person, and 1 is, I don't know. Okay. Why you are for the number 2? Do you have an argument for that?
Because it's got the biggest increase in relative to its money, its cost.
That's what I like more, that the biologist is giving the math answer to the engineer. Well done. So you are already saying that there is an incremental consideration you're doing. That if you divide 0.3 divided by 3,000, you get something, which is, or the other way around, 3,000 on 0.3, you get 30,000. If you divide 7,000 divided by 0.4, you get something less than 30,000, which is what we have in our next animation. I'm assuming that the willingness to pay the national threshold in the UK is £20,000 per outcome. We don't know what is the outcome, okay, in this moment. And if you work out the math, you are right. The ratio between the cost and the effectiveness is lower for the technology number 2 than it is for the technology number 3. Because if you divide, it should be the math. It should be the math in your handouts. If you divide 3,000 divided by 0.3, that's what you get. 10,000 per unit or whatever it is on this horizontal axis. If you divide 7,000 per 0.4, that's what you get, about 20,000. So something which is closer to the threshold. So they are both cost effective if you compare to the benchmark. So in this moment, if like then tomorrow, they are both into the system. But if I adopt the number 2, then the number 2 would be not anymore cost effective. Because when I move the center of my consideration here, and if the number 3 becomes the benchmark, then I have to consider that the difference is 0.1. Because it's 0.4 divided minus 0.3. And the incremental cost is 7,000 minus 3,000, which is 4,000. And now if you do the same calculation, it comes out that this one is not cost effective compared to the second. So that's what happens, because we introduced, as we saw yesterday, about thousands of new patents for medical devices per month. So this means a huge number of medical devices per year. So we need to be ready to understand that those things will change faster. Yeah,
did you say when if you made number 2 the benchmark, that the 0.4 would stay at 0.4?
No, because you have to say that your incremental increase of effectiveness is only 0.1. Oh, sorry, if I didn't do it. So if this is doing 40% better than the benchmark, and this is doing 30% better than the benchmark, it means that the relative increase is only 10%. You're right. You're absolutely right. I hate you. So if you work out the math, and this is now the benchmark, you see graphically that this is above your previous. That's what we tend to do. And in fact, the winner is number 1. Now, I could annoy you with the definitions of different kind of economic analysis. I could insist saying that you can do, first of all, the cost minimization, which is what we do when we have one outcome, one final result, which we consider to be equal for both technologies. Therefore, we can just focus on the cost. This is the basic analysis. You will never be in this case, but it's fundamental to understand the other. Then I can do a cost efficacy analysis in which I consider one clinical outcome, which I can represent in physical units. Mortality, blood losses. But what happens in reality is that this is not enough, because all your intervention will need to satisfy more than one clinical outcome, which will be different among themselves. So I need to introduce something else, which is what we call cost utility analysis, in which I still consider the input and quantify the input in terms of pounds, but I will consider more than one clinical outcome. And I need to define a utility function, which is a function I need to put together different domain of clinical health. You will see on the next slide what I mean. And then ideally, I can do a cost-benefit analysis, which is the case in which whatever clinical outcome I consider, I will convert it in pound as well. So I tell you, well, I need 10,000 million of pound, but you will gain 20,000 pound a mile of pound on a global scale, because my intervention will make people capable to work better or longer, and this will generate more revenue at national scale. I will show you one case just to give you an example later. How do I define a utility function? In this way. This is what we call QALY, Euro called 5D, which means 5 dimensions. I consider 5 dimensions: mobility, self-care, independence, pain, anxiety, and for each one I ask my patient before the intervention and after the intervention if they have any problem. And they may say, no problem, some problem, huge problems. If you work out the math, you understand that 3 to the 5th power is giving you all the possible level of health that you can measure with this approach. Plus 2 states: unconscious, the guy can answer; dead, the guy will never be able to answer anymore. So altogether, this is giving you a scale of 245 possible health status, which go from 0, no problem at all, in any of those dimensions, to the worst situation in which I have significant problem in all those dimensions. And then I can normalize those 245 different levels in a scale which goes from from 0 to 1 or from 0 to 100% in percentage. So once normalized, and I can say, well, my health condition is 0.4. So I can quantify this by measuring with the self-assessment those 5 dimensions. What it is relevant is that if I'm doing a comparison, I can run this survey across a huge number of patients which have been treated with this approach or with that approach, and I can measure after, I don't know, 6 months, what is the average quality of life in patients with this disease or with treated in this way or in the other way. And if one of the two is 0.5 and the other one is 0.4, this is my marginal impact on quality of life. It's a 10%. So that's the logic. It's only to pass you the idea that in my model you will have practical lectures and you will try this on real data. The only dimension which is missing here is the time, because you may have an intervention which will bring you at 20% for the first year, but at 100% in the second year, and so on and so forth. But you may have an intervention which brings you at 50% this year, then 50% next year, and then 100% in 3 years' time. So time, it's also a significant variable. And in fact, we consider quality of life as an area more than an individual one. Area coming from the fact that I have 100% of my quality of life for 4 years, and then I will die. So that's the area of my quality. And this is considered to be the equivalent of having a quality of life of 0.4 for 10 years, and then die. So the concept of quality of life is an area which is below this cube. And we consider 10 years at 0.10 as 1 year at 100%. There are economical reasons why to do that. You need a benchmark. As I mentioned before, I need to compare my intervention with an intervention for pediatric children, pediatric patient children. If I have to do that, I need a scale, because that's the only way I have, because otherwise if I use a more specific clinical outcome, blood loss, I cannot compare this from one case, which is a clinical intervention, with another case, which is rehabilitation. You don't have blood loss in rehabilitation intervention. So in order to have a comparator which is sufficiently general to be used in pediatric children, any kind of patient, older citizens, I need to define an abstract function, which is the utility function. So that's why those scales are introduced, to allow comparison among widely different healthcare conditions. There are algorithms which you can use in order to select the proper kind of analysis. So if the outcome of the first treatment is the same as the benchmark, then you just work out the cost minimization analysis, because if the outcome is the same, you can focus on the cost. But if the outcome is different, then you may have the same domain to measure the clinical outcome. We mentioned before pain, only mobility, only mortality, one clinical outcome, then a cost effectiveness is enough, or cost effective, well, depends if you have real life or not. But if I have more than one clinical outcome that I want to work on, then I need to define a function, quality of life, because I want to compare two interventions which they have an impact on mobility and pain, in which case I need the utility function. The fourth case, cost benefit, it's used only when you want to work in different domains. One is clinical, and the other one is education. If I need to compare a public intervention in the clinical domain or into the education domain, I need to do something else, because my information will not inform only the Ministry of Health, but the Prime Minister, which will need to decide how to invest the budget for next year, healthcare or education. That's the only case, in my opinion, in which you need a cost-benefit analysis. Otherwise, cost-utility should be able to solve the majority of your problems. Here, a more formal definition of incremental ratio cost, and here you can have efficacy, utility, or benefit. But I think the graphical representation that you saw before is enough to pass you the code. So, this is the value of life. That's one of the techniques which you can use in order to quantify in terms of pounds the utility function. The upper curve is the value of life of women according to their age. So when you are 30 years old, the value of this is a bit old, but you have a value of life for each year of life for women, and the blue one is for men. Why, in your opinion, this curve goes up and down? Why is not starting from there and goes down? Why the value of life per year, if I am 10 years old, is lower than if I am 30 years old? Yes?
It's because you contribute to society.
Because the society is contributing to person in several manners. Healthcare access, education, if it is public. And then when you are about 30 years old, 55, I mean, this is just an average of averages, you start to be productive for the society, and the society is not investing much money on yourself. And then it goes down, because at some point, you will need pension, healthcare interventions, and you are not producing anymore for the society. Now, you may like or not those scales, but you are using them every day. You know why every day you are using those kind of cubes? When? How did you arrive here today? Bus, foot, anyone driving a private car? Driving a car. Do you have an insurance? I hope so. Behind your insurance, there is this kind of cube, which will pay for a damage or for a loss of life according to cubes, which are kind of that. So you use those scales every day, and in a cost-benefit analysis, ideally, you would use those approaches. There are a lot of limitations, but and ethical problems, but it's an approach that, as I said, we use many times. Okay, we can stop here this lecture, and then in my modules, the one that we run on January, you will see two fields. We will enter more in details in the assessment of devices, which requires different attention than drugs for many reasons, which I will not touch today. And the other thing that we will cover together is this, that medical devices, and that's in the remit of biomedical engineering, especially clinical engineering, they are strongly dependent on the environment in which they are used, which means if your environment is standard, it meets very high minimum requirements, then we consider minimum requirements from the structural point of view, how it is designed in the surgical theater, technological point of view, what is the surrounding technology you need in order to use your medical device, organizational issues, if you are in the UK, know which kind of medical doctor you need to have for this intervention. And I will show you with some real case studies that if you start taking off this pillar, that pillar, then the same medical device is far less effective and far more risky for the patient. And one of the area of research is going on in my lab is the one in which we are exploring the safety and effectiveness of medical devices in lower-income countries. This is a case study I did in Benin, where I visited 5 different hospitals, and for instance, this is the voltage we were measuring on the ground. Ground voltage should be 0 if you measure across plugs which are one close to the other, about 0. We had value in the order of 100 volts. In this case, it was because this is an adapter without ground. So basically, the device is floating, which means that if you touch, you can die from electrocution, which is risky in surgical theaters. Or, for instance, this is a radiologic unit, and it was the best place to take a phone call. Radiologic units should be shielded, because they give radiation, which are dangerous. So the guy which is behind this wall, which was an administrative guy, and it was a side effect of the intervention. So one of the lines of research which is going on in my lab, it's about medical devices in lower income countries, which we think it's an interesting study to an interesting way to learn how to make more resilient medical devices also for research.